Dr. Pandey needs no introduction because he has been speaker to most of the CME and seminars in Varanasi. He passed his MD from BHU, Department of Medicine, then he went to KGMC to complete his DM Cardiology. Now after that he went to Bokaro as a senior specialist. Now from there he came back to Heritage Hospital as Director of Cardiology and spending several years in Heritage. Now he has joined the Galaxy Hospital where he is the Director of Department of Cardiology and doing very well. He is a very known cardiologist, not only clinical but international cardiologist. So with this background, I think further is not required because most of the people, they know more about him, So I request Dr. Pandey to proceed with his talk.
Thank you, sir. Thank you, Dr. P.R. Gupta, sir, for your kind words. Respected chairpersons, my beloved teachers sitting in the audience, because of them only I am here. I am really thankful to Hemant and Dr. Monica for giving me this opportunity to talk in between all of you. So the topic has already been discussed a lot by Professor Tripathi sir and Dr. Vagnu. My job is here to add few things which I have learned during my investigation of what is the importance of obesity, metabolic syndrome and cardiovascular disease. And I would like to highlight about one of the aspects in my future slide which Professor Madhukar Rai sir was discussing about, that why few obese individuals are metabolically healthy and what is this group of people. So as we all know, there is nothing more to discuss regarding the definitions of obesity. As we all know that excessive fat accumulation that presents a risk to health is really an obesity. But there are different markers. People have made BMI, body composition, body fat distribution, risk scores, comorbidities, but all these markers, they not define obesity exactly. And there are a few important ones which you all know, which are regarding as per the BMI, which differs from different ethnic groups, and percentage body fat, which has been taken by skin fold thickness and bioelectrical impedances. This was the IDF criteria discussed previously by the previous speakers regarding the different ethnic populations. But American Heart Association criteria gives about the waist hip ratio of more than 1 to 102 centimeter in men and more than 88 centimeter in women. As we all know that cardiovascular risk factors are top 6 leading cause of death, and that's why it has been discussed in each and every conferences and meeting. And you can see in this slide that childhood the obesity, overweight and obesity, physical inactivity are the two important factors which are very well seen in the graph compared to others like raised blood glucose and red blood pressure, which are also a part of metabolic syndrome. So cardiometabolic risk we all need to know, and how to measure a waist circumference. This slide is basically for my postgraduate colleagues, that many times we talk about the waist hip ratio, but how to measure a waist hip ratio is a very important aspect. So locate the upper hip bone and top of the right iliac crest and place measuring tape with the horizontal plane around the abdomen at iliac crest, and ensure the tape is snug but does not compress the skin, and this way we should better assess the abdominal area compared to the waist area. There is a global epidemic of obesity, as Dr. Tripathi sir was already discussing. We all know there are a few data published recently show that US population and the Chinese population around 49 to 50% of people are going to fall in this category of obesity. But why obesity is not a disease? Because it's a lifestyle choice. There is no specific symptoms associated with it. And it's a risk factor for disease and not a disease itself. And if we call it as a disease, then it is 1/3 of Americans as well as they will call ill and could lead to more reliance on costly drugs. And some people might be overtreated because their BMI was above a line designating them as having a disease. So, but obesity disease is also known as, because it's associated with impaired body functions. We all know that there are different metabolic abnormalities related to obesity, a lot of physiological dysfunction. It causes exacerbations or accelerates more than 65 significant comorbid diseases, and are associated with substantial burden of morbidity and premature death. And if you look into this slide, the obesity as a risk factor for a range of comorbid conditions like cardiovascular disease, diabetes, osteoarthritis, cancer, sleep apnea, Dr. Pathak was discussing, and cognitive and mood disorders, as Dr. Jhavir is going to discuss in the next coming slide. Basically, it's a failure of weight regulation, and many factors are operating. Dr. Madhukar Rai sir was discussing with a question that why Churchill was not having disease, but the genetic factors, developmental factors, environmental factors, many of them they operate upon obesity, and similar is for cardiovascular disease as well. Not only obesity or metabolic syndrome may not be responsible many times. We know that Asian Indian phenotypes, we are more predisposed for atherosclerotic disease. Our clinical parameters like waist-hip ratio, biomechanical parameters like insulin resistance, lower adiponectin and higher C-reactive protein, and metabolic abnormalities like raised TG and low HDL cholesterol are important for all of us. And different types of obesities are discussed in the previous speakers like apple-shaped obesity and pear-shaped. But in humans, obesity related to morbidity and mortality are related to not only to fat accumulation but also to the fat distribution, as Dr. Tripathi sir was saying. And particularly the apple shape or the central obesity contributes a higher risk than the general obesity, which is a higher BMI, to many chronic diseases like cardiovascular disease and type 2 diabetes. And this is how it looks like, that visceral or intra-abdominal fat is dangerous type of fat, which we all know about. Different macro environmental influences and micro environmental influences are operating for our obesity problem. There is a study which has been published in Lancet 2014 regarding the global burden of metabolic risk factors for chronic disease collaboration. And it was found that about half of the excess risk of coronary artery disease associated with obesity is mediated through the cardiometabolic risk factor, and half excess risk is mediated by the obesity itself. And this is the fact for abdominal obesity related to diabetes, and we all know that diabetes is one of the most important risk factors for cardiovascular disease. We were talking about the BMI and the life expectancy. There was a study published in Lancet 2009, shows the normal BMI almost 80% is the chance of reaching to 70 years, but the BMI of 40 to 50 with 50% chance of reaching to age of 70, and 35 to 40 years about a 60% chance of. So the longevity increases with the lower BMI. That's why the physically active people were more living for longer days. The future of metabolic syndrome, as we all know, the central obesity, hypertriglyceridemia, low HDL and hyperglycemia and hypertension. The same we are all aware about it. And IDF says that abdominal obesity plus two other components like raised blood pressure, HDL, or elevated TG and impaired glucose are responsible. When we should suspect for metabolic syndrome, usually it is an asymptomatic disease, so we have to have a high index of suspicion and increased waist-hip ratios with increased blood pressure. It should alert us to investigate these patients. And acanthosis nigricans, as Dr. Tripathi has shown in one of his diagrams, and this was the IDF criteria for diagnosis of, the modified NCEP criteria for diagnosis of metabolic syndrome, as we all know, and it is the most important classification. And this is how the acanthosis nigricans looks like, as well as some skin tags which are responsible for metabolic syndromes. The other conditions associated with the metabolic syndromes are cardiovascular diseases, new onset of CVD and early onset of CVD, ischemic strokes and peripheral vascular disease. Type 2 diabetes increases 3 to 5-fold, NASH, hyperuricemia, polycystic ovary disease, obstructive sleep apnea. These are all attached to obesity, and how these are really related. There are a lot of biochemical parameters and biochemical changes are going on, and there are a lot of products get released by adipocytes in obesity, And among them, the important are these, like non-esterified fatty acid, inflammatory cytokines, plasminogen activator inhibitors 1, adiponectin, leptin, and resistin. These all play an important role in obesity and metabolic syndrome. Obesity-induced metabolic syndrome is a multidimensional risk factor for atherosclerosis, cardiovascular disease, and type 2 diabetes, because they both go together hand in hand, and both of them leads to atherogenic dyslipidemia, raised blood pressure, raised plasma glucose, and they have got usually pro-thrombotic state and pro-inflammatory states, and these all leads to increased cardiovascular disease and many times sudden cardiac death. The insulin resistance associated conditions and the continuum of type 2 diabetes, these are all ongoing pathogenic processes which are seen with obesity and metabolic syndrome continuum. The risk of cardiovascular disease rises with additional risk factors, like suppose if we have only one risk factor of glucose intolerance and it gets added on with hypertension and dyslipidemia, the risk factors increases and the cardiovascular disease increases. And that's the real situation for all our cardiovascular patients, because most of our cardiovascular patients, they have a pre-diabetes or a diabetes. So unmasking the hidden burden of cardiovascular disease, we need to have some risk score assessment, and physicians use nowadays these WHO, ISH risk prediction charts, and they are really helpful. So we can use them to predict who are the people who are really high risk for having cardiovascular disease. Not only obesity is the only important factor, and this takes into consideration of presence and absence of diabetes, gender, smoking status, age, blood pressure, and total blood cholesterol. And with that, we can risk stratify them with the risk rather than 10% to risk more than 30%, and where we need to intervene in such patient, because all patients are not required to be intervened or attacked. Now comes the most important question, which is moving around in last two sessions, that who are metabolically healthy obese. Few of my colleagues and friends sitting in the audience were obese, but they're not metabolically unhealthy. So there's a group of people, those who called as obese with BMI more than 30, but normal cardiovascular risk profile. That's why, and what is that normal cardiovascular risk profile? It's a no increased risk for atherosclerosis and hypertension, an absence of dyslipidemia and hyperglycemia. They have a normal insulin sensitivity, preserved glucose disposal, and no increased type 2 diabetes. And these phenotypically, metabolically healthy of these, they have few clinical parameters that the HbA1c is less than 6, lipids are okay. But are they really healthy? The metabolically healthy obese are relatively few in number and are likely over time to shift to unhealthy side, and they become metabolically unhealthy obese. There's a clinical and functional characteristics which I have discussed in this slide, that metabolically healthy obese and metabolically unhealthy obese, there are anthropometric clinical status, physical functioning, and quality of life have been presented in this article published in Nutrition in 2016. And to the summary of that, this metabolically healthy and unhealthy individuals, it is said that most likely it's a transient state and indicative of delayed onset of cardiometabolic risk factors and comorbidities. And so-called metabolically healthy obese are probably not really healthy, and detailed workup should reveal a systemic inflammation and decrements in physical function. And treating the metabolically healthy for weight loss is therefore very appropriate. And weight loss with diet and exercise, or diet and exercise plus a pharmacological agent, can improve the comorbidities or prevent their onset. And it's important to achieve more than 10% of body weight loss to achieve a real health. There are few treatment aspects I have discussed in my coming slide, but one thing which is very important regarding obesity, that there are multiple subtypes of obesity. All obese individuals are not same. As my teachers sitting in the audience, those who are endocrinologists, they have taught us the different types of syndromes, the different types of hormones deficiency, like leptin deficiency, LPR deficiency. There are different types of obese people, those who are exercise sensitive, sleep sensitive, insulin induced, metformin responsive, so many of them. So the disease of or complication, the obesity is not similar in every individual, and same is the complication of obesity. There are 65 odds complications of obesity are seen in metabolic, structural, inflammatory, degenerative, neoplastic, and psychological. And we need that these are the targets which needs to be taken care of, like fatty liver, sleep apnea, inflammatory and autoimmune disease. There are different 12 types of cancers. These are basically medical complications of obesity which we have to look into. Cardiovascular disease is one important part of it, but there are many of them which you can see in this descriptive slide. So the core principle of obesity treatment for us is lifestyle intervention, medication and surgery. Surgery will be discussed by my colleague who is going to speak next to us regarding the bariatric surgery. Medication, I will try to speak some small part of it. And lifestyle intervention really is the most important part of our management nowadays. But what differs among the different obesity subtypes are timing of obesity, fat location distribution, metabolic consequences, phenotypic differences, response to environmental causes, because now all of them they don't respond to the similar type of environmental causes, and response to therapies as well. If you look into the different metabolic complications, the overall treatment strategy for the obesity is self-directed lifestyle changes, professionally directed lifestyle changes, medications, weight loss surgery, and post-surgical combination therapies. They are the mainstay of treatment for obesity. The lifestyle treatment, a healthy diet as we all know, but to change to the nutrient environment by changing the diet chemistry and regular exercise, stress reduction as we have discussed. Stress is going to be a most important aspect, and the benefit of modest intentional weight loss is tremendous, and it gives a lot of information in this slide that how this modest intentional weight loss is going to help us. And the effects of moderate weight loss on cardiometabolic risk factors are very clear over the week's time. And this slide, which is from an article published in Diabetes, Obesity and Metabolism in 2002, shows that the weight loss is one of the most important part in management. And there's a very important trial called as Look Ahead trial, which shows that importance of more than 10% of weight loss. And though they initially showed no significant reduction in the primary outcome of cardiovascular disease incidence in adults with type 2 diabetes, but however the post-hoc analysis over a median of 10 years found that the group who has lost more than 10% of weight in initial first year of study had 21% of lower risk in the primary outcome. So that's very important, but weight loss is really difficult, as is the prevention of weight gain. And the change in weight from baseline to the clinical trials were seen with different drugs like orlistat, naltrexone and bupropion combination, and recently liraglutide. So these are the few important drugs which have been used recently. And we all know that the BMI and type 2 diabetes has a linear correlation. There are a few slides which I'm just going to skip because of the paucity of the time, but it gives a very important clue of how to regulate the food intake regulations. There are different mechanisms operating at central nervous system, different hormones they get released from the GIT, and the models they are there to summarize that the hypothalamic arcuate nucleus is responsible for operating these, and the adipose signals which are giving leptin and insulin, and satiation signals from liver and stomach, that the hormones which are released are responsible for this satiety and obesity. Gut peptides, these are the few gut peptides which are anorexogenic and orexogenic, like ghrelin released from stomach is orexogenic. There are a lot of neuro mechanisms which are operating upon, and I think my colleague Dr. Venugopal will be going to discuss upon these hypothalamic appetite regulatory system and how the psychotropics are going to help. There are different congenital deficiencies like leptin deficiency which presents like that. And so to learn from these slides that there are two peripheral signals and satiety signals, adiposity signals are there, and the two new pharmacological agents, the phentermine, topiramate and lorcaserin, they act as the primary neurons to alter the neurotransmission, and hedonic signals pathway is responsible for liking and craving. A few points regarding the obesity pharmacotherapy. It's basically an adjunct to the lifestyle modification and not a substitute, can increase the chance of meaningful weight loss. And when it has to be used, when non-drug intervention should be attempted for at least 6 months for considering the pharmacotherapy, and in patients those who have got a BMI more than 30 or patients those who have got BMI more than 27 and above with concomitant disease and risk factors like type 2 diabetes, dyslipidemia, CAD and sleep apnea. And there are different complex mechanisms for drug actions. I'm not going into the details of that. These are the list of drugs, but to highlight at least these are the few important drugs like lorcaserin and phentermine tocomerate. These are the two important anti-obesity drugs which have been used. And the newer drugs which are emerging as a pharmacotherapy are naltrexone, bupropion and liraglutide. And my endocrinologist colleagues, they are very well versed with these drugs. There are a lot of anti-obesity medications and development. Early stage has caused induced weight loss and maintenance at 1 year, but definitely the weight loss and prevention of new disease onset results are published in SOS study, and liraglutide has been used in a scale study. There are a few words regarding the bariatric surgery, though it will be taken as a specialist consideration, but definitely it has to be used in BMI more than 30 or 35. The details will be discussed. So we have few choices for anti-obesity medications. The two new medications have been approved in 2012. Medications are always only adjunct to diet and exercise, and when we have more medication, we will treat obesity more frequently. There are few important investigative tools to detect coronary artery disease in obesity and type 2 diabetes or metabolic syndrome patients. And I would like to stress upon the multi-detector CT screening as a 5-year all-cause mortality among asymptomatic diabetic patients. And this is one of the most important study which has shown that it can be held as a very primitive screening tool, though it's a costly affair, but it's a very important screening tool for atherosclerosis, which is basically non-obstructive and even in an early phase. So if you want to look into the summary of treatment for metabolic syndrome and obesity, definitely A, B, C, D, E, F is a really important aspect. A, when the dysglycemia is there, targeting the HbA1c, and to reduce the cardiovascular risk, the multiple risk factors are there. Aspirin, blood pressure control, you all know detail about it. Cholesterol management, cigarette smoking, diabetes and pre-diabetes management, exercise and food choices. So I'm not going into the depth of the treatment for statin, blood pressure medications and all those, but tobacco cessation algorithm is really very important. And my psychologist and psychiatrist colleagues, they really require their help, and it is the most difficult part of the therapy in cardiovascular disease prevention, particularly obese people and with metabolic syndrome. Regarding the physical activity, what is the recommendation? The recommendation that advise people with or without diabetes or metabolic syndrome to perform at least 150 minutes per week of moderate intensity aerobic exercise, and physical activity should 50 to 70% of maximum heart rate. Many times, many of my colleagues ask me that what should be the grade of exercise. At least the heart rate should go to 50 to 70% of maximum heart rate, and spread over at least 3 days per week and no more than 2 consecutive days without an exercise. And in absence of contraindication, adults with type 2 diabetes and metabolic syndrome should be encouraged to perform resistance training at least 2 times a day. The randomized control trials have assessed the role of pedometer, as Dr. Madhukar Rai sir was saying about the importance of walking every day. At least 2,500 steps per day is really important. Nutritional, physical activity and NCD prevention, at least 80% of heart disease, stroke and type 2 diabetes, over a third of most common cancers can be prevented by eliminating obesity, unhealthy diets and physical activity. So there's really a need for all these interventions. So at the end, I would like to summarize that obesity, metabolic syndrome are important milieu for cardiovascular disease. So we have to accept it and try to take care of them. Different complex pathophysiological factors are operating for development of cardiovascular disease in obese and individuals with metabolic syndrome. Few persons with diabetes and impaired glucose tolerance are appropriately controlled for key measures of HbA1c, BP, lipids and weight control. Combined control of risk factors can result up to 50% reduction in risk of cardiovascular disease. and the greater adherence to lifestyle modification and use of guideline-based and newer therapies can help us address remaining residual risk. Treatment of obesity is really complex, but the lifestyle modification is core but very difficult option. And a few medications work by different mechanisms. I will discuss about them. And the bariatric surgery is an important for morbid and severe form of obesity. My other colleagues will be discussing about them. So thank you all for your kind attention.